Hi everyone, I'm Chinmay Jani, Chief Fellow at University of Miami in Hematology and Oncology at Sylvester Comprehensive Cancer Center and Jackson Memorial Hospital. And today I'm going to talk about precision oncology in lung cancer. I'm going to walk you through some cases on how decision making is done with the help of precision oncology, especially next generation sequencing, as well as how these cases are discussed in tumor boards. So very patient friendly approach and how you would be walking with us as if you're part of the team when we are discussing these cases as well. The objectives of this talk is, first of all, to understand the role of precision medicine and multidisciplinary tumor boards in non-small cell lung cancer, to evaluate the role of liquid biopsy and its utilization in decision making, and along with that, also different types of NGS as well, apply learning through case-based discussion, and highlight the importance of clinical trials in non-small cell lung cancer care as well. With this, first of all, non-small cell lung cancer, it's a very heterogeneous disease with multiple actionable molecular alterations now that we have been studied, and also treatments are available as well. It is molecular profiling is now standard of care, especially in advanced and metastatic settings. And with advent of various newer targeted therapies, treatment selection and sequencing is constantly evolving. So there is a newer problem that we have in thoracic oncology, which is a good problem to have, that now we have multiple treatments available on how to select the most appropriate for each patient. And that's why precision, as well as on how to sequence based on what treatment was given to each patient before. And at the same time, multidisciplinary discussion is therefore extremely important and a key to personalized medicine. So this is how non-small cell lung cancer used to be. If we talk about like 15 years ago or like even like a decade ago, this is how non-small cell lung cancer was used to be seen as just as one entity. However, now with the molecular testing and precision medicine, we have following types of lung cancer: EGFR, ALK, ROS1, RET, KRAS, also ERBB2 based, BRAF, NTRK, KRAS, MET, NRG1, and still a big portion of non-small cell lung cancer are those who do not have any actionable alterations. They might be having some other mutations, but not currently actionable alterations in non-small cell lung cancer. This I took from NCCN guidelines, but again, it's constantly evolving. Focusing a little bit on stage 4 with non-actionable mutations. So in this patient population, platinum-based chemoimmunotherapy is a standard first-line treatment for most of the patients, which means chemoimmunotherapy combination. There's a double chemotherapy with platinum plus something else. So it can be platinum with pemetrexed for adenocarcinomas, or platinum with paclitaxel or Taxols in squamous cell carcinoma, along with immunotherapy backbone. And these combinations are given as a frontline approach. However, despite initial benefit, most patients then eventually develop resistance, and then the cancer comes back, or cancer starts progressing again, with around 70 to 75% of these patients experiencing progression within 5 years and limited molecular guided therapy in second line strategies. And when there are limited guidelines, that's where more kind of discussion and multidisciplinary meetings become more important. In such cases, ctDNA enables real-time assessment. And here in ctDNA, I will also mention overall next-generation sequencing for tissue or ctDNA, which is liquid biopsy as well assessment, helps in understanding and assessing evolving genomic landscape at progression, including emergent actionable, prognostic, as well as resistance-associated alterations. And then post-progression genomic insights can inform rational second-line treatment selection and eventually third-line or fourth-line treatment selection, including targeted therapies, as well as various newer novel therapies, including ADCs, which are antibody drug conjugates or bispecifics, and so on and so forth. Just quickly showcasing how the current NCCN guidelines looks like here you can see that preferred therapy is also along with that other recommended therapies. And this is how it looks like for second line therapy. And here you can see there are some preferred, some preferred based on mutations and other recommended. But as you can see, there are like multiple different treatments. And for each particular patient, precision approach is extremely necessary and helpful for better outcomes as well. And you can see over here too that newer ADCs are now available as well, which can be utilized in such settings. So with there, quickly, I want to talk about, I've been talking about this NGS and precision biomarker testing and NGS as well. But what is NGS? It's next generation sequencing that helps us enable and understand what kind of different biomarkers are available or what kind of different biomarker or alterations are expressed in biopsy which is collected for each patient. And this biopsy can be collected in various different ways. It can be done by endobronchial biopsy, transbronchial biopsy, VETS, which is like a surgical procedure, or transbronchial needle aspirations, bronchial brushings, or just liquid biopsy. And as a patient, sometimes you would hear all these different kind of approaches. I would put it simply in two ways. One is this tissue biopsy, which means that the biopsy is taken from your primary lung cancer or from metastatic sites, sometimes like liver or some other lymph node or some other places as well. And then the second one is liquid biopsy. And liquid biopsy is basically similar to as if you're collecting blood sample from your blood vessels.